started in just a couple of minutes.
I will try again to reconnect because my audio is very slow. The image is good, but you know your
Okay.
voice is very
No,
delayed.
that's just me. Good morning, Sandeep.
Hey Doug, how are you?
Good. How are you doing?
Good, good. Must be
Good.
early morning for you. Hi, Joachim.
Morning, Andrew.
Good morning. How's it
Hi.
going?
All good here.
Good.
It's only 9 o'clock. It's not that early.
I know, I'm East Coast as well.
Yeah. Is Vasilis on yet? I don't see Vasilis yet. All right. Okay, it is now 9 o'clock Eastern time and whatever time and wherever you are. So I think we will get started. Welcome everybody to the sixth World Spinal Column Society Spine Board case review session. We have three cases that we're going to go through today. We have a very good panel. And we are going to start with our first presenter is from Hamburg, Germany, Joachim Oertel. Can you share your screen, Joachim, and we'll get started?
Yes.
And there we go.
Whoa. Wait. I have a problem today, whatever that is. Let me see. Okay. You see it? Do you see the screen?
Yep, we see your screen.
Okay, perfect. Yeah. So nice. The first case is from Mexico, and it's a 32 years old male. Well, has some cardiac and aortic history. I think it's unrelated to the case. The patient is suffering from cervical pain, symptoms from 9 years, so very long history. Numbness and tingling in left fingers, radiating to the left, from the left side of the neck down to the fingers, and there's a not further specified weakness of the left arm. This is the examination. So you see muscle strengths. You see, let me just do this. Okay, you see on the left, he has a weakness for biceps and triceps function and some extension and, a flexion of the fingers. There's a mild difference in the reflexes and no symptoms on both legs and the right arm. Well, but then he also has a lower cranial nerve lesion, so 11s and 12s, weakness of head rotation, head anteflexion, and slurring of speech. And well, Hoffman and Tromner sign, I think it's not that important for this case. Okay, we further proceed. The first thing which was done is X-ray imaging. Well, the only thing you might notice is in the flexion extension, I don't see, it's a very, very flexible cervical spine. But in the obliques, you see particularly on one side, you see there's a large neuroforamen in C2, C3. And Yeah, this is the most obvious finding in the X-ray. We further proceed, and then we come to the MRI. So there's a T2 weighted image. Sagittal image, you see there's a big mass from the part of the cerebellum and brainstem down to minimum C3, C4. On the axial, we see here that there's a lesion which extends through the foramen to the extraspinal part, and there's a narrowing of a minimum of, well, probably all this is tumor in my opinion, and this is the compressed spinal cord. Difficult to judge by just one image, but I think that all this is tumor, and this is just a septation of the tumor. So basically, all spinal canal is compressed by this lesion. And this is, again, a sagittal and axial. Again, T2. This is here the neuroforamen, so more lateral. And you see here, I think it's a little bit more up. You see here that the dens is in the center. Basically, here's the remnants of the spinal cord, and everything else, the spinal canal is completely filled with tumor. So extension of the tumor is 7.19 centimeters. So down just to basically almost the base of C4 here. And yeah, it's a long tumor with probably extra axial. You see that there's a rather compression of the spinal cord, and then there's a spinal cord tumor, intermedullary tumor. We go to the CT. CT shows some already chronic compression of the bone. So you see some resorption of the bone on the left, where you had all the tumor. Besides that, there was a angiogram done. Well, the angiogram shows a reflux from the, if we do it again, you see there's a reflux from the probably right to the left vertebral artery. Here you see the axial imaging corresponding to the angiogram. You see that here the vertebral artery is open, and here it's quite difficult to really identify the vertebral artery. I doubt that it's that far lateral. Let's look at the angiogram again. Difficult to say. But at least there's definitely a compression of the vertebral artery on the left side.
Mm-hmm.
So what can we do with the case? What is the most probable type of spinal tumor? What is the best approach? Would you perform fusion surgery in this case? And how often use functional evaluation scale? How often do you use this? Okay. I think this is quite a range of interesting questions. So the most probable type of spinal tumor, in my opinion, as I said, it's an extraaxial tumor, compression of the spinal cord, it's widening of the neuroforamen. So this is very, very likely it's a schwannoma. Any other opinions? Can we discuss this, or how can we proceed? Doug, what do you think?
Yep. Sandeep, Vasilis, anybody, any thoughts?
Yeah, neurofibroma is also on the differential. I think schwannoma is probably higher, but possibly neurofibroma.
Mm-hmm. Sandeep?
No, you have to switch your audio on. We cannot hear you. Switch it on. You're mute.
Imad, can you turn Sandeep on?
Yes, sir. Yeah.
Are you there, Sandeep?
Can you hear me now?
Yes,
Yeah.
we can hear you now, Sandeep.
Yeah. So either it's the schwannoma, neurofibroma. Practically, they are the same thing here. But I think it's an extensive neurofibroma, and it is mostly on one side. So obviously, it needs surgery. So what did you ask?
We were just working on the diagnosis and we're about to move
Right.
into how you'd like to treat it. So why don't you go ahead and start with how you'd like to treat it?
So it's vertically, the extent of the tumor is quite large, and so sometimes when the tumors are big and in C2 foramen only, and then coming, there's a large extraforaminal component. Then sometimes I go I take retropharyngeal approach for those tumors. But here, if you see, the extraforaminal part is not that big, and the spinal component is quite big, and vertical extent is also quite large. So I will go posteriorly, and perhaps I'll do a hemilaminectomy at 3 levels and then remove the tumor.
Okay.
And
Something I
don't
missed
see
in
the
the investigation is whether there was ataxia as a sign of a myelopathy. I'm very sure that this patient cannot walk normally. I doubt it, because this is really a severe compression of the spinal cord. But you never know.
It's been there for so long, it can sometimes surprise you.
But definitely, I think the easiest way is probably in my opinion, posterior laminotomy. So we would put back the let me see. This is probably, we would do C2, C1. You have to take. You even have to do a little bit of opening of like a little craniotomy. Without craniotomy, it cannot be done, in my opinion. So it's craniotomy 1, 2, 3. And maybe you can just thin out 4. So it's quite a big approach. But I think midline is easiest in this situation. It's not a good case for a lateral approach.
Yeah, I agree. So in my hands, I would do probably a little bit of suboccipital craniotomy all the way down to C4. I would start probably at C4, find normal spinal cords and normal dura, and kind of work up from there. I have other thoughts, but I'm curious to hear what other people think as well.
Yeah, we would exactly do the opposite. It's a typical case we would do in semi-sitting. So we would start from most cranial part and then just use gravity, and it comes out nicely. So the different ideas.
Okay.
But you said sitting, you do it sitting?
Yeah, semi-sitting.
Wow, okay.
One of the questions asked by the person proposing this case was, do you think they need fusion plus minus instrumentation?
Yeah, in my opinion, I don't think there is any instrumentation required here, because you're not destabilizing the spine.
We should preserve the facet. I mean, what is left? Actually, we can do laminotomy on the, probably what we saw is the C2 and C3. I think the C1 is not intact anymore. I interpreted it this way. So you can put back actually lamina of C2 and C3. It's not a high risk of instability, I think.
Other thoughts? Or is everybody just going to decompress this?
Decision I would make during surgery. I would be prepared to fuse. I am concerned about C1, C2. I would try not to go that far to destabilize the facets and the joints, but I would be prepared to fuse if need be, depending on what I see in trial. My main concern on this person, I know it's on angiogram, and it looks like that left vert is not dominant, but I certainly would, kind of back of my mind, would be worried about a vert injury on this guy if I go and chase that tumor laterally. One thing we have been doing in our practice is we put like a sheet in the vertebral arteries for difficult cases like this. We have the intervention radiologist, or depending where you are, it could be neurology or neurosurgery, coming in and do like a vert injection and then do an O-arm spin. And that way the O-arm spin is not just like a CT, becomes kind of a CTA, so you can visualize the vertebral arteries. And that way, when you're resecting tumor, or if you end up putting screws, then you know exactly where it is and you can avoid it. So that's something that we've been doing. We've done it probably 4 or 5 times so far.
This is a
Right.
big advantage when you use the semi-sitting because you just follow the vertebral artery from intercranial part. It's very easy. So it's very easy to localize the artery. It's not easier to preserve, but to see it, it's easy.
Got it.
So what are you going to do for that foraminal and extraforaminal component?
Well, I think the extraforaminal component is not that big. You
Not
see
that big,
here,
yeah.
I think this is actually, I'm not sure whether this is just fat. I don't think that this is still tumor because when you look here on the right side, this looks just like fat. So I think the extension of the tumor is somewhere, the outer limit, it's somewhere here. So I think this area, this is barely more than the lateral aspect of the C2. So I think you can actually reach this with a posterior midline approach. If it's more than that, I don't know. It's a schwannoma. They grow very, very slow. So if there's any doubt, it's too far lateral. I think the main goal here is to get a diagnosis and to the decompression of the spinal cord and the brainstem. So I would not bother if I left a small part behind.
Sandeep, your thoughts?
No, I asked because I do a lot of radiosurgery also. So for these extraforaminal components where we are not going to remove it, I later on treat them by stereotactic radiosurgery.
It's a reasonable
Well,
option.
in my opinion, it depends a little bit on the histology, because I think schwannoma, it's more likely that we do radiotherapy, and neurofibroma, I would probably wait and watch and wait. Anyway,
Just your reasoning for watching and waiting if it's a neurofibroma.
in my opinion, when you have decompressed the part, they grow very slowly.
All right. Andrew, anything else you want to add?
As I said in the beginning, I think it's rather a schwannoma. So because we don't see any other lesions, so it's I think it's probably a schwannoma.
Okay. And the question was asked also about functional evaluation scales.
Yeah, what is that? I've never heard that before. What's a functional evaluation scale?
Oh, I'm wondering if they're talking about, using a
You're monitoring?
no, more like using, say, a JOA score or something like that to just monitor or to look at outcomes. That's my assumption. Is the author of this? I thought I saw the author of this is on the call. Ahmad, could you unmute him?
Imad?
Yes, sir.
Yeah, can you
can
unmute the author of the guy who submitted this? Is he here?
I thought I saw that it's.
So can you show me the name?
I agree with you, Doug. I thought he was there.
Daniel Juarez Rebelar. Any luck, Ahmad?
Sir, I need the name. Can you show me the name? Spelling.
I show you the name.
Yeah,
Here.
there it is there.
Oh no, it's just his picture.
Yes. Yes.
Yeah, but
Oh
his
yeah,
name's
here's
there.
the name.
Yes,
Yeah.
he's there.
Oh, okay. He actually just added on to the tech. He just added on to the chat.
Yeah.
He said basically SF36 or McCormick score. So he's looking at what outcome scores would you use in this? Would you use, and what outcome scores would you use in this? Any thoughts?
It's difficult to decide because we had actually no real deficits because since we only have the biceps and triceps mild weakness, I think no score will be really very helpful in this case.
It's also what what is the purpose you're using the scores for. I mean, here this is a kind of, most of the scores are designed to look at degenerative problems. In something like a tumor, it's either do they have a deficit or don't they? So I'm not sure that and what an SF36 is going to capture in a case like this, I think is a little. I'm not sure there's a lot it's going to capture.
Yeah, I agree.
Okay, well, I think that is enough. Why don't we now move on to the second one?
Just one
Sorry,
question.
go ahead.
How
Yep.
many of these surgeons present here actually would treat the residual disease by radiosurgery? Because I have experience of now more than 20 cases of extraforaminal disease, and which we are treated by radiosurgery with excellent results. I think when Yoko mentioned that one would wait and watch, then waiting and watching becomes a very tricky thing. Sometimes you lose the patients to follow up. They follow for a few years, then they forget about the disease, and there is always a risk that the tumor may increase in size. Once you treat them by radiosurgery, that risk significantly reduces, and then one can breathe easy.
Yeah,
So I think it's a good idea to treat the residual disease by radiosurgery. It's a pretty safe procedure.
Okay. Thank you for that addition.
I think it's different in the cystic or the solid. This is I didn't see any cysts, so I think this is very unlikely to have a significant regrowth in the next 10 years that you need radiotherapy.
Well, and I think a lot of this too depends on where you're practicing. I think the chances of your patients following up, Yakam, are probably significantly different than the chances of Sandeep's patients following up.
Yep.
So I think that does make a difference. If you're in a practice where you're able to keep good track of your patients, great. But if you're not, then I think being a little more prophylactic, such as Sandeep is proposing, is a good plan. All right. We are going to move on now.
It's a nice case, a very big
good.
tumor. Very nice case.
Yeah.
So I stopped my screen sharing.
Okay. And I think Sandeep, you're up next.
Yep. So I'll share my screen. And so I had this case sent to me. Can you see my screen?
Yes. We do see your screen.
So this case is from Joris Elisokas. I hope I'm pronouncing it correctly. Joachim, you are a German. You tell me what's the pronunciation. It's from University of Saarland.
No, he's not German. He's
Okay.
we pronounce it Joris Alisauskas. I think it's right, but maybe Joris is here. I don't know. Is he here?
No, sir, he's not here.
Okay.
Is Joris Lithuanian?
Yeah, yes.
The name is.
All right.
Okay.
Now that we have that sorted out, why don't we get on with the case?
So the history is that this is a 74-year-old male Caucasian patient. He has pain in right lateral thigh and hyposthesia in the right foot for the last 2 months. His VAS score is 8 to 9/10. And he has a reduced walking distance to 100 meters. And it's an uncertainty by walking. I presume that he means instability in walking. In the comorbidities, there is polyneuropathy. There is history of inguinal hernia on the right side, and the history of lumbar facet joint injection for chronic back pain. Now, the foot dorsiflexion, plantar flexion on the right side was 4/5, and there is hyposthesia on the right foot. So he straight away goes to surgery. But so this is the MRI, and so this is a preoperative MRI, and here you can see that in the right L5-S1 foramen, you can see this lesion here, and here in the MRI quality is not great, but you can still see a lesion here along the S1 nerve root on the right side. So it's about a 13 millimeter into 8 millimeter tumor.
Sorry, the L5 nerve root, not the S1 nerve root.
Which one is it?
Because you're in the L5 foramen.
So this will be L5 nerve root.
Yeah.
So now, so he was operated on. He was recently operated. They did the dorsal decompression. They resected the lesion, did a duroplasty with autologous fat patch, and the biopsy was a schwannoma grade 1. And he had pretty uneventful postoperative period, and no weakness in the legs, no hyposthesia. And in the follow-up, he had no pain radiation, no paresis. He had pain in both feet, residual, but probably due to polyneuropathy. And so this is his postoperative MRI. And you can see here that a hemilaminectomy has been done, and part of the facet joint and pars has been removed. Now, and again, it's difficult to see in this MRI, but apparently you don't see any tumor there. It's not a good contrast image, but Yeah, but if you see in the foramen, it looks good, quite nice. So apparently the tumor was removed. And now the questions are, what approach would you take, midline posterior versus endoscopic, and preservation of the affected nerve root, patient's quality of life, etc., versus risk of recurrence, and whether it is arising from the sensory root or motor root, and whether that would change your surgical approach. I think one should add here whether one would fuse it or not also.
Yeah, I think that's a good plan too.
Yeah. So, Joachim, you tell me, what would you think about it?
Well, obviously is a case from my hospital, but I don't remember the case. I think when I look at the pre-op MRI, I also would think about just a disc prolapse, sequester disc. Go one back, Sandeep, to fourth. You see that?
Yeah, yeah.
And well, this is a very different approach then. So somehow I guess that there's another MRI, maybe with contrast, or maybe there's something that gives us more suspicion that this is a tumor, because you don't see any widening of the foramen. So right now, with these two images, I would guess probably it's a disc prolapse, and this makes a big difference because I think the intra-extraforaminal disc prolapse is where the lateral endoscopic approach is the best treatment in my opinion, but you cannot treat the schwannoma here. So I think it's very, very important to have the pre-op imaging and to make your idea, make up your surgical plan based on the idea what is the most likely diagnosis. And obviously there are some aspects which point to a tumor. Maybe the history. Can you go back to the history?
Yeah, history doesn't really suggest any tumor.
Because usually the pain and weakness and like a claudicature, this is not very typical combination for a tumor.
It's also the relatively sudden onset of the symptoms is not typical.
Very interesting.
But out of curiosity, why would, because I don't do endoscopy, that's why I'm asking you, why would not you do tumor by that endoscopic approach while you would do a disc?
No, the pure endoscopic technique, you have only one working channel. It's under continuous irrigation, and you can really not manipulate. You cannot resect, in my opinion, a schwannoma without high risk from the remaining nerve tissue. And so we can do a tube-based endoscopic procedure, but then we would do midline, and this is exactly what approach was chosen. So like Matrix or Easy Go, whatever you can do, that's not an issue. But the sheer transforaminal endoscopy, I think it's very difficult to remove a schwannoma and preserve the remnant nerve root. I think it's, in my opinion, there's nothing which has not been shown, but I think it's not the way you should treat this.
You can't put any counter tension on to allow you to dissect.
Nothing. You cannot separate the tissues. They have no bimanual technique. Yeah.
Okay.
Wesley, what would you think about it?
One question, because I don't do endoscopy also. If we think that this is a disc prolapse and we go with a lateral endoscopic approach, is it possible, and when we understand that this is a schwannoma, is it possible to take it out, or we have to change approach?
So I guess what he's asking, Joachim, is if you got in there through an extraforaminal approach and found it was different than you thought, what would you do?
Well, I think I would just discontinue the approach and switch to an paramedian incision. This is the big advantage of the approach, is that you basically have no collateral damage. You just have an endoscope of 6 mm, and this is what you bring in. And then you notice it's a schwannoma, it's a big nerve root, there's no disc prolapse. I would just remove the endoscope and, prepare a midline approach.
Okay.
And the second comment I would like to say is that when you see this far lateral tumor, you know that you will have to take out most of the facet in order to really deal properly with the tumor and preserve the nerve as much as possible. So I believe that you have to have a fusion there, since the facet will be taken off. You need to be prepared with instrumentation.
I think this is a big difference between the orthopedic view and the neurosurgical view.
Yes,
A facet joint, taking a facet joint means nothing to a surgeon, neurosurgeon.
I
It's very
understand that,
funny.
and there is a question about the age. He's 74 and he's not young anymore, less activities. I understand that. So this is a real...
Actually, in my opinion, when you look at the left, the mid left, you see that the facet is preserved to some degree. It's not really taken completely. Maybe it's 50% preserved. The mid left and the upper left, and then you see there's some preservation. It's not, not touched at all. That's true. There's some degree of facet. There's some part of the facet is taken, but not all of it. I think I would wait probably.
Joachim, so you would say to him that I'm not planning infusion, but if it hurts in the future, I will go then and stabilize it.
In this patient, what is in favor of non-fusion is that I think with almost 80 years, he's probably already fused. What was the age? 79, right, Sandeep?
74.
74. Okay, but still, it's very likely that you have some stability already because of degeneration. Actually, MRI looks quite good for this 74.
Would you be thinking differently if this was 44?
I think the risk of symptoms by taking the facet later on is higher, but I would not fuse. And just prophylactic fusion we at least don't do.
I think it also depends on the country. I mean, I'm a neurosurgeon as well, and in the US, I would say over 90% of neurosurgeons would fuse this because of the degree of facet disruption. I'm not saying it's the right thing to do, but I think in our practice, we in the US would much rather kind of prophylactically fuse someone rather than have them come back in 6 months or a year and having to do another surgery. It's really frowned upon to do another surgery on a patient you did surgery on recently. So I think in most places, I don't know, Doug, if you agree or not, in most places in the US, this would be decompression, resection, and fusion at the same time.
I think that's probably it's probably true that most centers in the US, this person would have had a fusion, yeah.
I'm not saying it's the right thing to do. I'm just saying it's the mentality and the legal environment in the United States is maybe a little bit different than Europe.
I think it really has to do, it's difficult without having all the cuts to know just how well preserved that facet is, like how much facet is left and how much pars is left. Yeah. And I think that would be sort of, it'd be a thing of while you're there going, how much have I taken? Can I get away with it?
Okay. So would anybody manage this with a non-operative approach?
I'm still having trouble with this case understanding why there's sudden onset symptoms from a slow-growing tumor.
So if we go back to history, and so he has some hypoesthesia for the last 2 months, and he has reduced walking distance. Now the thing is, in post-operative period, there is no obvious weakness, no hypoesthesia, but there is pain in both feet even after 6 weeks, which is probably because of polyneuropathy. Yeah. So it's very difficult to say how much symptoms are there because of polyneuropathy and how much is because of the tumor. And again, there was very mild weakness. It doesn't mention whether weakness improved or there is no increased weakness.
No weakness, no paresis.
So that means
And
that
after 6 weeks.
did improve. Yeah.
Yeah.
But considering the age of the patient and the symptoms are not that mild, would one want to consider to observe it or treat it by radiosurgery?
Can we, is the writer on display to ask him what was the fact that instead of thinking about the disc prolapse, it made him think.
Yeah, unfortunately, we don't have the author of this on the call today, so we can't ask.
So I had an experience of a case where he was referred to me, and he had a slightly bigger tumor than this in L3 foramen. And the previous surgeon actually went by midline with the tube and went on the wrong level. So they explored, did not find, found some tissue, came out, and post-op MRI revealed that the tumor was still there. And the only symptom the patient had was some radiculopathy. And the patient was absolutely unwilling to undergo another surgery. So, and the tumor was about double the size of this tumor. I explained to him that what the best option was that we take out the facet joint, remove the tumor, and fuse him. But he was not absolutely willing for surgery. So we ended up doing radiosurgery. And surprisingly, he did very well. His radiculopathy disappeared in 2-3 months, and the tumor shrank and became smaller in size. And he's doing very well after. Now it's been 4-5 years, and he's still doing very well. So that can be an option in certain cases. Though, of course, surgery remains the best and the first option. But still, anybody who doesn't want surgery or cannot undergo surgery for any medical reasons, radiosurgery still remains a good option.
And then there's questions about preserving the nerve root. How would you go about doing the best you could in terms of preserving function? Thoughts?
It's the same technique as we did with the other case. So I would come from the intradural part, see the origin of the tumor, and then separate the healthy fascicles from the fascicle which is growing the tumor, and dissect that. So I think it's important to come from the intradural part to really differentiate between good and bad, and then resect under preservation of the remaining fascicles, the pathological fascicle.
Okay.
I think it was done here because at least they say duroplasty, fat graft. So yeah. I think they did come from the spinal
Inside
canal.
Out. Yeah. Okay.
Yeah, not
infrequently. In post-op MRI, you can still see the nerve there.
Yeah.
So nerve was preserved.
Okay.
Yeah, not infrequently in those cases, I've seen fascicles that are very adherent. They're normal fascicles and they're not in continuity with the tumor, but they're very adherent to the tumor and very difficult to separate. And for those, we usually use neuromonitoring and we stimulate them. And if they're non-functional, then we can take them as well. So I think neuromonitoring is also helpful in these cases.
The difficult thing here, in my opinion, is that it's such a small tumor and a brief history. But usually these patients are diagnosed very late. So they have tumors, very big tumors. And then, in my opinion, it's frequently that you can resect the whole root, because there must be some reorganization of the nerve system, because you don't have any weakness later on. I think it's a long period of the disease that they reorganize the innervation somehow. Particularly in the lumbar, I don't remember when these big schwannomas come. I don't remember that a single patient had a weakness later on. Although frequently, as Andrew said, it's not possible to preserve all the fascicles because they are so chronic and so adherent. It's very difficult. So even this is a rather difficult in this case because the tumor is so small.
Mm-hmm. Okay, and we have time now for the third case.
Yes,
so let's move on. So Vasilis, do you want to share your screen and
yes,
case 3?
Yes. Sorry. All right. This is a case from Homburg Saar again, from Dr. Karen Radke. It's about an elderly lady, 85 years old. She fell on the sidewalk, and the emergency imaging in another hospital was a non-displaced fracture of the odontoid process, and it showed an older fracture of the C1 arch. Patient wanted conservative treatment with fitted cervical orthosis. There were no deficits and some neck pain. The patient had adequate cognitive status, no sensory or motor deficits. She was able to walk, and the neck pain was 2 out of 10 when it was stable, but it was changing to 10 out of 10 with any kind of movement. We see here on the radiological imaging, there is a fracture line here, and here.
So why don't we stop there and
Yes.
just look at how people would manage this? An undisplaced odontoid fracture, 85-year-old woman.
Let's talk about the classification first of the fracture.
Okay.
Yeah. Any comments?
Feel like we need more cuts. I'm not really seeing a very clear acute fracture. I mean, I can see some fracture across the anterior C1 arch, maybe something involving the anterior dents, but nothing posteriorly.
Yeah.
So I'm not sure.
I would say that this part is like an osteophyte, so this is a lower part of the C1 arch plus the osteophyte. It looks like an hyperextension movement. It goes from anterior superior to a little bit posterior and lower part. It is definitely, according to Anderson Alonso, type 2 fracture.
Yeah.
And according to Gower or the older classification, Roakamigi, it's type 2, again, from superior to inferior on the posterior part.
So how would you want to manage this, Vasilis?
We have we published back in '98 when I was a young doctor a paper at that time at the orthopedic and related research, a review of 55 fractures like that, all going with conservative treatment and with a success rate of 90% of fusion.
Fusion or healing?
I want to say that according to our knowledge, this is the worst type of fracture, because this is the area that is doing most of the non-fusion cases, because the blood supply and the bone quality is the worst position. But in my opinion, I would go conservatively. It's a non-displaced fracture.
Sandeep? No. Joachim, what would you do? Well, Sandeep finds the on button.
Sorry.
Not. Sorry.
No.
Yeah.
I was speaking but didn't realize that I was muted. So
Okay.
she's an 85-year-old woman. It is an undisplaced fracture. I will not operate her. I will just put her in a cervical brace and wait, observe.
Well, the problem we have. Sorry. The problem we have is there is just in these very old ladies there's a risk of pseudarthrosis. So
Yes.
probably if it was my patient, I would discuss this, because if in my opinion, if it's like this and you put 2 screws in, the risk of pseudarthrosis is very, very low. If you treat it conservative, the risk of pseudarthrosis is maybe 20%. But of course, you have to add the risk of surgery, which in my opinion, I think is very minor, because it's just a standard ACDF approach. I cannot say that I would do surgery on the patient, but at least I would discuss it with the patient, because you know what we are left with is 2 months later pseudarthrosis, and then do we come from anterior now, or do we then posterior? And posterior means fusion of the segment. So actually, this is something where I probably would do osteocentesis prophylactically,
So
or
you're
at least
saying-
recommend. I always explain the patients that when you look at the recommendations, the guidelines from the German Society, we would not recommend surgery. But in my opinion, I think they do better with surgery.
When you say standard ACDF approach, what do you mean? Are you talking about?
No, it's a standard anterior approach, ventral approach, and then just putting 2 screws in.
So where are you putting the screws? I'm not sure. Are you talking about an
odontoid screws?
Or
this is also a good case for anterior screws.
Anterior screw, odontoid screw.
Because we can see here that there is a little listhesis on the C2, C3, so the screw will go straight forward up there.
Yep.
And the Gower type 2 case, that this is the case, it's completely indicated for anterior approach screws. But I want to also point out that this is a hyperextension fracture. So if we put a proper orthosis stabilizing the head from hyperextended, we can keep this area immobile, and then, as Joachim said, it's 20% of pseudarthrosis. So we have an 80% chance of fusion.
Okay, Andrew.
I think it's actually better than 90%.
Yeah.
If it's like this, the perfect alignment, and you put in 2 screws, there's no movement. I think
No, we're talking about the 80% he's talking about is conservative.
80% is conservative. Yeah.
Yes.
Andrew, your thoughts?
I'm interested to hear more about the 2 screws. When we train, we only put 1 odontoid screw. I've never seen 2, so that's.
It's a Synthes Depu system. We always put 2 screws. I mean, we started with 1 screw, or if it's possible, 2 screws, because the nice thing is that it's rotational stable. You know, it cannot rotate. Even if you have a small gap, you don't have a perfect alignment, they're still quite fixed. In this case, probably it would not matter. Yeah, because you have a perfect alignment.
Yeah. Almost no one in the US would put in 2 screws.
Yeah, so we have always put in 1 screw with absolutely perfect results. So I've never had any problem with a single screw.
Yeah.
If you get a good lag with your screw, you get rotational stability.
Yeah.
And you have more bone surface area for healing. So it even when Ron Applebaum at Salt Lake was doing these like on everybody, he was putting only 1. He went quickly away from 2 screws into just 1.
Actually,
that's why I love those meetings, because I'm learning how it's done in other countries, and it's fascinating how it's different. Yeah.
The two
In my
screws
department,
were
it's almost
actually
mandatory to put 2 screws. They have to explain why they didn't do 2. But if you don't know the Synthesis system, the screws itself, they're very slim. So there are different systems available. And earlier we had 1 screw only, which was much bigger. So maybe it's also an aspect.
Okay. So this particular case, they had elected to treat non-operatively. And if we can move on now, Vasilis, with the next bits.
Yes. And then in 6 weeks later, no adequate callus formation and beginning displacement of the odontoid tip. And you can see there is a minor displacement here. Actually, there is still a connection on the posterior aspect of the odontoid process. And here we can see some displacement.
Are we really seeing displacement, or really just seeing a little bit of bony resorption that's the first part of bone healing?
If we can go back and see, I believe that we definitely have some displacement.
So I think before we move on, can we talk a little bit about when we say non-operative treatment, what did we do? Was it just bracing or was something else done? Maybe
I am talking about Philadelphia or Miami collar.
I would typically use a Miami.
Yeah, because in our practice, we use Miami as well, but we also give them a bone growth stimulator and we put them on calcitonin. I don't know if other people have other thoughts how you treat your fractures conservatively to try and help autofusion without surgery. Anybody else, any other ideas?
I have never done anything other than a collar.
We used to do only collar. Now we do also vitamin D and anti-resorptive medication. Yes.
Okay, thanks.
We have done quite a few some cases with a halo, but I think this is not very helpful because it's so many complications with that.
85-year-olds die in halos. I would never put an 85-year-old in a halo. I think a halo is more lethal than surgery in an 85-year-old. So if it came down to a choice between a halo and surgery, I would be doing surgery 7 days a week. No, it's
that's what I think. I mean, the alignment was perfect, so I think it's a easy case to put maybe 1 or 2 screws in, So and also you see that it's easy to put it in the base of the dents because you have the C2 3. There's enough space, and the C3 is actually a little bit posterior to the C2, so I think it's a good case to put in odontoid screw.
Go straight from here. You have a very good line.
I guess the question that I have coming from this case that we don't have the answer to is, how is this patient doing symptomatically? Because that's going to make a huge difference in what I do. If I saw this CT, but the woman is now pain-free or near pain-free, I would continue on with my non-operative care, which we don't have that information unless the author
But the patient developed pain, huh?
We don't know. It doesn't say.
The patient was developing pain when there was some movement. If there was no movement, here it says 2 out of 10 when it was stable, 10 out of 10 when with any kind of movement.
But that's at the initial exam. That's at the initial exam. We're now 6 weeks later. See, if this was a CT scan done because of ongoing pain, that's one thing. If this is a CT scan done to assess fracture healing in somebody who's clinically improving, I think that's a huge difference in terms of what I would do next. That's just a piece of information, unfortunately, we don't have.
I think that most of these patients, even with resorption and no callus formation, they improve. They have improved symptoms, and usually these pseudarthrosis are pain-free.
Which brings the question of, do we treat them?
Yes, we had at that paper we had follow-up of these pseudarthrosis cases, and they had a good life in the long term, even with instability movement. We did flexion extension X-rays, and I'm talking about a follow-up up to 30 years. From 18 years to 30 years follow-up, and even with pseudarthrosis, most of the cases had a good pain-free life.
Anybody other thoughts at this stage? Andrew?
No, I mean, I agree with how this patient was managed. I would say I would have started with conservative treatment as well, non-operatively. And exactly what you said, Doc. So if the patient currently has no symptoms, no pain, and worsening of the fracture, I would probably, image her again in maybe 6 weeks to 2 months. If she's developing worsening symptoms, I think a lag screw, odontoid screw would be a good idea.
My problem here is the duration. Now it is already 6 weeks down and there is no healing. So this is sort of a cutoff period for me, because if we delay it further, and suppose if she heals, well and good, but if she doesn't heal, then in the end we'll end up doing a posterior fixation, which will be a much bigger surgery for me in this situation, rather than putting in a simple anterior odontoid screw.
When you say healing or not healing, so if you had this woman,
she develops pain.
Yeah, that's what I was going to say. Because if you had this woman at 4 months out, pseudarthrosis, but pain-free, would you
Then
operate
perhaps
on
I
it?
won't do anything.
I think it depends a lot on the situation of the condition of the patient. Doesn't mean anything to me if it's 85. They're 85 years old, which work every day, and they play tennis, and then I think you cannot leave it like this. But if you're quite,
If she's
old
asymptomatic,
in your
if she's
daily
asymptomatic,
habits, I think it's different.
you would still treat an asymptomatic pseudarthrosis in an 85-year-old.
If they're very active and doing sports, yes.
So I will tell you, in my hospital, we get consulted all the time on patients on their 90s and 80s because there is an incidental, type 2 odontoid fracture that's chronic. And you go and talk to them and they tell you, oh yeah, I had a big car accident or a fall or whatever, like 10, 20 years ago. And I know about this fracture. And they're just, the dents is hanging in there. It's all corticated. It's old. They have no symptoms. I mean, those people are fine. I mean, you don't operate on those people. So I think if I don't know, but in my practice, if the patient is asymptomatic, regardless of how this looks like, I wouldn't operate.
I would agree. I can't see the point. What are you doing? What are you improving in this person's life by operating on them if they're asymptomatic? You're making the X-ray look better. If you're doing a C1, C2 fusion, you're removing a whole bunch of motion to make the X-ray look better.
No, I thought we discuss the second image. The second image is the image of the image interpretation. I think is the most difficult part, because if it's still healing and there's the status of bone resorption, you can still put an odontoid screw in, as Sandeep mentioned. If you say there's already pseudarthrosis, then you cannot put in a odontoid screw in anymore.
But we're just talking. I was just sort of speculating about how you would treat the asymptomatic pseudarthrosis late, not where we are right now.
Yeah,
because I think the issue with where we are right now is and as I said, what I would do here is entirely dependent on what this person is telling me in terms of symptoms. if I'm seeing this CT, but somebody who's asymptomatic, I'm going to treat it very differently than somebody who says my neck still hurts and I see this CT. If their neck still hurts and I see this CT, yes, at this stage I'm going to do an odontoid screw. But if they're asymptomatic, I'm not going to treat this person. Not treat them surgically, I mean.
Okay, I think they in general are not very painful, these odontoid fractures. So
yes,
that means that you don't treat anybody, even a 40-year-old, you would not treat then. Is that right?
40-year-old I would. I can't remember the last time I acutely treated an odontoid fracture in somebody over age 80.
So I have operated 2 patients. One was 83 and he lived to 101. So he died just a couple of years ago. And another patient I operated was 90 years old actually, and she was in extremely severe pain and not getting better with any medicines.
Yeah. No, I think if they're pain, so my treatment protocol for the elderly odontoid fracture patient is put them in a collar, start weaning them out of the collar at 6 weeks. If they're pain-free, great. I don't even care what the x-ray looks like. If they have symptoms, you treat them based on the symptoms that they have. Okay, nobody else wants to comment?
No, I agree with you, Doc. I
Yeah.
agree with him.
Yeah. Okay, well, we have come to the end of our hour. I'd like to thank the faculty for participating, and I hope participants have learned a lot, and everybody have a good week. Thank you.
Okay. Thank you, Doug.
Thank you, everyone.
Bye-bye.
Thank you.
Thank you, everybody. See you soon, huh?
Thank you, Joachim.
Bye-bye.